when I went there, my dad, who was a country doctor, said, you must go and study with a surgeon who was a classmate of mine. His name was Norman Barrett. And he was become very famous, got some disease named after him. He didn't understand it, but it was stuck with him ever since. But by and large, so I studied esophageal surgery for a little while. I went to his teaching clinic, which is one of those Roman amphitheater things. And he was right down the bottom, and I was the only person there in his teaching clinic at the back row, which struck me as rather odd. And he ignored me completely for a while, and eventually said, hey, you, have you come to learn? I said, yes, sir. And he said, how tall was Queen Victoria? Which wasn't in his book. And so I stammered a little bit and said, so he said, 4 feet 11 and a half, don't ever forget it. I've never forgotten it, I've never questioned it. And ignored me for another 30 minutes and then said, you're still here, you've learned something today, go away. And that was the end of my surgical career. So I started looking for something else to do after a while. And I chose gastroenterology because it seemed to be the simplest specialty. It was contemplative, we had very little in the way of diagnostic tools, there were no scans of any sort, there really wasn't any useful treatment of any sort, and surgery was dangerous. We worked with barium, and the only instrument I had was a little proctoscope, maybe. And I actually ended up working with an internist who was interested in small bowel disease, and so I actually spent the best part of a year not scoping anybody because we didn't have scopes, but taking biopsies from the small intestine, working with Brian Creamer in what was called the Gut Hut, which is a research in Quonset hut in the back of St. Thomas's Hospital, working on small bowel lipids in thin layer chromatography. And it became very clear to me and to Brian very quickly that this was not my career path. I was not going to be a basic scientist. And so we were looking around for something else to do, and I'd heard about gastroscopy. I said, Brian, what about this gastroscopy business? He said, oh. He said, we tried that, we've got one of those. He said, it's in the closet, you're welcome to use it. And I went and got it, and there it was. The semi-flexible, so-called semi-flexible gastroscope. That was in that closet then, and actually, it is now in my possession. It was given to me a few years ago when I visited St. Thomas's. It's rather nice to have it. But he said, you know, we tried it. It was pretty uncomfortable. Couldn't really see very much. And nobody believed what you said you could see. And so we kind of gave it up. And then he said, tell me when you can take a biopsy, because that might actually make it useful and even respectable. And it just so happens in that same year, 1968, the first commercial gastroscope appeared, at least in Britain, the first Olympus scope, and I'd show it here. This was a publication from the Oxford group, and you may be surprised to see that that's a side-viewing instrument, since we nowadays use mainly forward-viewing scopes, but that was because it had relatively little tip deflection. You put it in the stomach, rotated around, and you could get extremely good views of the stomach, and indeed take biopsies. So the Japanese were really only interested in the stomach because of their gastric cancer problem. They weren't interested in looking at the esophagus or anywhere else at that particular time. So Brian was kind enough to say, well, we'll get one of those. And we got one of those, and I passed it down a patient without ever seeing a procedure done in my life because nobody else was doing them at the time. And we learned pretty quickly that this was actually something quite useful. And within a year or two, still in training, a so-called senior registrar at Thomas's, I was running an endoscopy unit. Nobody else was the slightest bit interested. And this is a picture that appeared on the front of one nursing magazine. On the left, Sue Wright, who was the first, I think, endoscopy nurse in Britain wearing her Florence Nightingale hat, slightly bored biochemistry tech waiting for take a biopsy, me sitting down with a forward-viewing scope, and an interested radiologist actually looking sharing the view. So this was what it was like in 1970. Thank you. We had a very efficient unit. So this was the sort of workhorse that we used in the early 70s, a forward viewing scope from Olympus, which, as you can see some of the details, is a fiber optic scope. So we had a camera that we could screw on the end, a side viewing so-called lecture scope that you could screw on the scope, and so somebody else could see what was going on, biopsy. And one of the things that might be quite interesting was that, in fact, the biopsy port was just where your left eye is. So if you're looking through this one was squirting stuff in your left eye at the same time. Nowadays it's moved down here somewhere, it's more convenient. So we went through a very interesting decade where most of the areas that we now explore were explored, including EGD and including what we called coloscopy to begin with. And then along came the ERCP, although it was not called ERCP at that time. My mentor, Brian Creamer, came back from the World Congress in Copenhagen in 1970. He said, I can't believe it, but I saw this guy, Taro Oy, showing some pictures of getting x-rays of the bile duct and the pancreas. And it sounds like something you'd be interested in, Peter, so you better go to explore that. You better go to Japan. And he managed to arrange some money from the British Cancer Campaign to allow me to go to Japan. But he said, I want you to do me a favor. He said, on the way, I'd like you to check in to help someone starting a place that's just starting a new medical school. It's in Shiraz in Iran. He said they need some help there, and I'd like you to go there, but only for 6 months, and on your way to Japan. And I went there as a 30-year-old with a young wife and very young children to experience biblical medicine. It's stuff I just read about vaguely and never really thought I'd ever see. I actually took a scope with me, I think the first scope in the Middle East, and I discovered that the cause of dysphagia in Iran at that time was actually leeches in the esophagus, because they got stuck halfway down the esophagus. And I developed a new technique for removing them, which I can explain to you in detail if you like. But I went on to see conditions which I was, as I said, aware of, but had never tried to treat. And to try and treat some of those things in a hospital that had very little money, sort of no insulin, no antibiotics, and a few things like, trivial things like that, to try and deal with some of that stuff was really quite extraordinary. On a Monday morning, I came in to do a ward round with my registrar, who spoke French and Farsi, and I didn't speak too much Farsi, but I spoke a little French, and he took me to see a patient in the corner of an open ward like this. The patient obviously had a fever because they had a fan which was rotating around him to try and keep him cool. And he had a rash, and I said, what's that in French? And he said, I don't know what that is in French, but we went and had a look at a book, and it turned out to be smallpox, and we had over 100 cases of smallpox before I left. It was an extraordinary experience for, as I said, a rather young man. Anyway, I ended up in Japan, and that was the first pancreatogram I produced with Kazuo Ogoshi. As you can see, the traditional Japanese long scope approach. We hadn't learned how to straighten the scope at the time. And my career was almost stopped at that point by this person here, who was Ogoshi's boss, Professor Hara, who knew I liked to play golf for some reason. He came in each day to the endoscopy room and said, we go play golf. And I said, excuse me, I prefer to stay here if you don't mind, sir. He got very upset. But eventually we did play golf, which was an embarrassing experience. So the next question is what to call this thing. The Japanese had difficulty with pronouncing the first line. The second line was what they called it. When I came back to London, I said, we're going to call this thing pancreatic biliary cannulation, which seemed a good idea, not least because it happens to coincide with my initials. But unfortunately, as you know, there's some rotten liver disease that got PBC. So we ended up calling it ERCP, and this was actually ratified at a World Congress in Mexico City by some of the leaders at that time, Laszlo Safrani from Hungary at that time, Einar Klassen, Kazagay, Jack Venice from the United States. So that was an era of diagnostic explosion, followed by an even more exciting period of time where the therapeutics came into being, during which time most of the stuff that you do today, or a lot of it anyway, was developed, not by me, but I certainly jumped on it as quick as I could and tried to do it and teach it, evaluate it a little bit. As far as ERCP and sphincterotomy is concerned, I'll take you to 1973, by which time we'd been at it for a couple of years and doing a lot of it, got to get a lot of visitors. And we had a Swedish surgeon in the room who saw us with a stone in the bowel, not that one, a lot smaller one than that, but anyway, he said, why don't you remove it? I said, look, you're welcome to watch, you can applaud if you like, but don't make stupid remarks, because I had absolutely no idea that we were going to jump into sphincterotomy and stone extraction, well, I say very soon. When I say we, of course, I did not invent any of that. The first sphincterotomies were done in Japan and in Germany almost simultaneously. They've jointly claimed precedence. And if you're interested in knowing more about the early days, then you can read my book, The Tunnel at the End of the Light. And then on page 80, you'll find a nice description by Bernie Lawrence, my good friend from Perth, one of my very earliest trainees, now retired, of course, like everybody else, who actually wrote an interesting anecdote about my first sphincterotomies and indeed my first adverse event. So we're moving on to that. The next big therapeutic development, of course, was stenting, which mine with Nib Sahendra and his colleagues. Nib's still going strong in Germany. That really, the two of them launched us into a therapeutic adventure, which continues to this day, which supported my career and gave me challenges and a lot of satisfaction. At the same time, we had a lot of problems because we were trying to apply all this stuff in an environment, particularly the National Health Service, where the resources were pretty pathetic. So we were trying to organize ourselves without any roadmap. Nobody had really told us how to do that, and try to get money to do these things, buy scopes. I remember when I went to Germany in the late 60s, I went to a private clinic and where there were all sorts of scopes hanging up. I think I had one or maybe 1.5 at the time. I said, where'd you get all these scopes? He said, I write checks. So, oh, okay, I've never tried that. But anyway, trying to put together a system to allow us to be able to provide efficient services was tough. Of course, it still remains tough, but it was very difficult then when people had no idea what we were trying to do. And even more difficult, it was the whole training paradigm, because we had our own trainees, but also all the people who'd trained before the sort of endoscopic era wanted to come back and learn a lot about it. So there were a lot of people who wanted to learn. And the problem was we didn't have the tools. We had this teaching attachment thing that you screwed onto the scope, and a big great line of people waiting to have a sort of little glimpse down this thing, which actually darkened the light so much neither of you could see very much, until the TV cameras got small enough to be able to hang them from the ceiling and screw them onto a scope. So this is in the Middlesex in the, I guess, the early 1980s. And then, of course, everything changed rather dramatically with the video endoscopes that appeared in the early 80s. This is Rob Hawes, our good friend who trained with me in London, using the first Olympus video endoscope. And those tools, the TV camera and video endoscopy, allowed us to actually then transmit the images as we do routinely nowadays. And I was able to keep my unit afloat in London by actually selling tickets to American gastroenterologists who wanted to come and sit in my seminar room and watch ERCP while their wives went shopping and they all went to the theater. We had a good time for a couple of years. And with all that video stuff, of course, we were able to transmit not only next door, but also into my office. So I was able to supervise the 3 endoscopy rooms I had at the time from my office. and I was able to watch ERCP and cricket and Wimbledon all at the same time. When I moved to the United States, I tried to translate that into being able to watch on and advise people from my golf cart, but that didn't seem to work very well. So let's move on from that. As I said, we had a therapeutic revolution, and that led to some anxiety, particularly amongst some of the establishment, because there were some very early significant turf issues. One of which was with the gastroenterology establishment, who didn't like the fact that all the young people wanted to go into the endoscopy lab, not to the basic science lab. They were very dismissive, some of them were indeed. And indeed, even the British Society of Gastroenterology, because at that time, you couldn't actually join the society unless you'd been a consultant faculty position for a couple of years or something. So all the people who were doing the procedures, like myself, were not eligible to join the BSG. So we actually eventually we set up an endoscopy society, of which I was the last president, because I, in fact, abolished it eventually back into the British Society of Gastroenterology. That's another story, but the bottom line is there was a lot of resistance from the establishment. Chris Booth, who was the president of the BSG in 1979, came up with this little quote, which has a certain resonance. And then a good friend of mine, Solly March from Cape Town, who was the godfather or grandfather of South African gastroenterology, said to me, "Peter," he said, "you need to consider the whole patient and not just the hole in the patient," which has a lot of resonance, I think, in modern gastroenterology. But the other turf issue, of course, was the competition with surgery, because in Britain, at least, medicine and surgery had diverged sort of 400 years ago. There were royal physicians who gave you potions and bled you, and then there were surgeons who carved you up after they'd cut your hair or whatever, the barber surgeons, so-called. And it became very clear in the 80s that we were stealing a lot of surgical turf. It was obvious that removing polyps endoscopically was rather smarter than doing open surgery, et cetera, et cetera, et cetera. Anybody can make a list of the stuff that used to be surgical. And don't forget, the surgery was actually kind of dangerous in those days. Bile duct surgery, the experts were bragging on a 5% mortality for common duct exploration, seriously, because surgery was very dangerous. Of course, that's no longer the case, but it was clear. So we took over a lot of surgical turf. I was very fortunate at the Middlesex in having a team approach, an interventional radiologist, imaging radiologist, both of them excellent, and a wonderful surgeon called Chris Russell, who was extremely supportive, got me out of all sorts of trouble and encouraged me in all sorts of different ways. And when I said I was leaving to move to the United States, he said, "Peter, you may have a little bit of difficulty in the United States where they're a little bit more concerned about their individual turf." He said, "Surgeons have all sorts of diplomas on their walls to say what they're entitled to do." And he said, "I'm going to give you something to put on your wall so that they'll know where you're coming from." And this is kind of what he gave me. Because if you think about it, it's brutally true that I ended up being a pancreatic and biliary surgeon without any of those tickets, although I actually did get an FRCS down the road. And when I came back and bragging on that to my surgical colleagues in Charleston, I said, "I am now a card-carrying surgeon, FRCS London." This guy, David Adams, who was my chief of GI surgery there, said, "Terrific, I need someone to be on call for trauma at the weekend. You demand." So I sort of backed off a little bit. So I left London in 1986, as you heard, moved to the United States. I actually moved initially took a sabbatical at the Medical College of Georgia, where I was kindly invited to spend some time. And that was actually an extremely important time in my life, but for two very good reasons. One was I met the young lady who became my beautiful wife, who is sitting in front of us here. And also because I was introduced to Ian Taylor, who had just become chief of GI at Duke University and who was looking for somebody sort of like me to set up the endoscopy and interventional stuff at Duke University. And so I made the decision at that stage to move to the United States. The National Health Service at that time was very poorly resourced. Things have improved quite a lot, but at that time it was really, really tough. At the Middlesex Hospital, which was a 500 or 600 bed university hospital, there was only one gastroenterologist, that me. And I was doing acute medicine as well as GI. There was one other guy who was supposed to be there, but he was always in Harley Street all the time. That was tough. I could handle it, in my 30s and early 40s, but it became rather tough after a period of time. It was helped for a while because I was able to accept Australians, and I had a lot of great Australians came to work with me. Bernie Lawrence from Perth, Tim Heap from Sydney, Tony Spear, some of you will remember those names, some of them going back a while. But anyway, we had these people who came on their own money and came and worked with me. And so we actually had a reasonable sized team for a little while until the hospital realized that they were actually bringing in patients, which they didn't like because there was no money coming with those patients. So they actually said, we're no longer going to allow you to bring Australians in to work at the hospital because we have to feed the patients, put Band-Aids on them, et cetera, et cetera. That was the sort of last straw as far as I was concerned. Anyway, so back to med-surg collaboration. The problem, it was somewhat acute in the United States because I discovered that the departments of medicine and surgery were very separate, actually often physically separate. Surgeons always had a new building somewhere, some distance away. But the fact is that, of course, medicine and surgery grew up from these different roots with different traditions, with sort of tribal cultures. Lots of fun talking about the others in a derogatory way, and also the physical separation. And also the fact, which is a little bit more subtle, but also equally important, that in an environment dealing with complex cases, we were seeing different parts of the elephant. So, the surgeons were telling me that cholecystectomy, for instance, was a great operation, but I knew better because every day in the RCP room I was dealing with people who had a problem after their cholecystectomy. And equally, the surgeons, when they saw a patient for surgery with chronic pancreatitis, they'd say, this patient's had 3 RCPs already, why do they keep doing it? It doesn't work. I thought it worked from time to time, but the fact was there was a lot of, because of this separation, culturally, tribally, physically, a lot of misunderstanding, and I didn't like that. Having come from Middlesex where we were all together, crunched together because there were so few of us and no one cared what everybody was doing, that came as a big surprise to me. And I became concerned that in fact patients, a bright yellow person would actually bouncing around between these disciplines without much in the way of collaboration. It was also obvious that gastroenterologists and interventional radiologists and surgeons were actually looking remarkably similar. They were all gowned up, wearing gloves, using instruments and looking at TV screens, and yet they came from different roots, and it seemed to me sort of kind of illogical. And it seemed to me that what we should be doing was actually putting the focus firmly on the patient in between. And I wrote about that in some detail in Journal of Gastroenterology in 1994, that I don't think anybody ever read, certainly didn't pay much attention to it, but basically saying that this digestive world needs to come together. This separation is ridiculous and is getting in the way of decent patient care. And that's actually the reason why I moved to Charleston, South Carolina, a beautiful city for those of you who have not been there, because I was given the opportunity by Ian Taylor to develop a multidisciplinary digestive disease center, which was designed to put patients first and also as an academic institution to provide the environment for the research and education needed to improve it. That's been a wonderful 25 extra years in my career before I stopped hurting people. I'm still there from doing some research and some teaching. And still trying to understand where it's all going, which is very tough. I had a difficulty with vision, as other people have had in the past, as you may have seen this particular slide before. This poor fellow's having a little difficulty seeing the future. But my prediction, for what it's worth, and my predictions in the past have always been wrong, is that a lot of diagnostic stuff is being done and will be done in the future by specially trained nurses and technicians with increasingly intelligent endoscopes. Some people have the difficulty with the concept of intelligent endoscopists, but I'm talking about intelligent endoscopes. And in fact, I saw this very early on in my unit. I noticed on one day that there was a little crack appearing in one of my scopes, and as I watched it, this great big brain burst out of it. And don't misunderstand me, this is serious, because without question, we are seeing a new era with artificial intelligence changing what we do. And in future, these intelligent endoscopes will do a lot of the propelling and steering. They will recognize where we are and what we're looking for. We'll track the quality. We'll be able to track usage, etc. And also, with picture-in-picture, we'll be able to remind us what we're supposed to be doing when we come across something really tricky. So this is an exciting future, and I'd be very surprised if it didn't come to pass. What will gastroenterologists do if all these procedures are done by people without all that fancy training? Well, certainly we would hope that they would be supervising these teams of non-physician clinicians who are doing a lot of this work. Hopefully we'll have more time to actually listen to patients and actually talk to the patients, which in the United States has changed. All of the gastroenterologists in practice have physician assistants, so-called, or nurse practitioners. They do the talking, the doctors do the scoping. And I keep telling them it's not very popular. It should be the other way around. So you should be talking to the patients. The nurses should be doing the procedures. But anyway, so but also a lot of new stuff, and there will continue to be new stuff. It's very easy for somebody like me to think that we've lived through the sort of golden age, it's all downhill, but that's always a mistake, because all exciting new things are happening. As you're very well aware, all sorts of attempts to do fund application. Many companies have gone bankrupt trying to do that. Many of you in the room are taking out huge chunks of the stomach and colon and things like that. Scare me to watch that. The third space is the most amazing place that people have invented suddenly. It's a new territory to be getting under the mucosa and doing all sorts of things as described here by J. Pasricha going back almost 10 years ago. And then thinking very well outside the box, I take some credit for holding a meeting in 1998 in Charleston, where we got a few of the opinion leaders together and asked where should we be going. And Tony Kalu from Hopkins said what you need to do is to perforate, which was not a good word to most gastroenterologists. It's not something you want to do, but as you know, this was the idea that if you drive through the wall of the stomach or wherever, you end up in a whole new area to play around in. And in fact, I was part of the Apollo group that described some of the early procedures like gastroenterostomy performed endoscopically, and that was the beginning of the NOTES paradigm, where all sorts of things were suddenly done through the mouth or through the vagina for that matter. And there was a sort of race to describe the first this and that could be done without scars. And it was clear that these things were actually remarkably feasible and remarkably safe. And the question mark was why on earth you need to do that when modern surgery and laparoscopic surgery was pretty effective. And we thought that it was actually a good idea because this was less painful. There were less adhesions, at least in the animal work that we did, and we thought that people would be happy not to have any scars at all. But as you may know, the NOTES paradigm really hasn't taken off for a number of reasons. What it has done, however, is to actually develop a lot of new tools. And it's kind of like going to the moon. There wasn't too much point in going to the moon, but in doing so, you develop a lot of gear that's useful in everyday life now and in the future. So radical endoscopy, so-called, spurred the development of new tools, such as we are mainly using today, including the endostitch, the overstitch, which I had something to do with development from the Apollo company. The other big thing, of course, is bariatric endoscopy, which has got to be growing. Obesity is a huge problem all over the world. Endoscopists do a good job of dealing with things that aren't quite right after a surgical bypass or resection or whatever. Gastric balloons have a long history. They were knocked back sort of 20 odd years ago, maybe more than that, with one randomized trial that suggested it didn't work. But now, as you know, they've come back and they're quite widely used around the world, including in our place. But the most exciting thing is the gastroplasties that are being done around the world. And there was, I think, a seminal paper that was presented quite recently in GIE from endoscopic sleeve gastroplasty, which actually showed very impressive total weight loss and pretty impressive excessive weight loss. This has got to be coming in a big way. The other big concern that I've had over the years is quality, partly because as I get older I begin to feel more like a patient than a practitioner. I'm a bit concerned as to who's going to deal with me. I'm okay when in my hometown. I feel sort of okay when I'm here, but I'm a bit nervous. So I dragged off some remote golf course with cholangitis. Who's going to actually take care of me under those circumstances? So we all know that quality is doing the right thing and doing it right. I don't have time to go into discussing training and documenting competence, but that is a big change that's come about in the last decade or so, with a lot more detail about how to train and how to assess whether people are adequately trained. I've been actually personally more interested in stringent research to try and evaluate what is really, really worthwhile, because no question of doubt about it, the earliest endoscopic therapies that we came up with were obviously better, safer, cheaper than what was around already. You didn't need a randomized trial to show that taking out a polyp with a colonoscope was better than open surgery. Forget it. It was very obviously the case. But times have changed, and we now know that minimally invasive surgery is now very safe. It's extremely unusual for somebody to die of surgery unless they were dying before they went into surgery. And equally, we're beginning to realize with more stringent research that some of the things are perhaps not as effective as we would like them to be. For instance, management of chronic pancreatitis with the RCP there's a lot of iffiness about that. A lot of stenting, a lot of sphincterotomies, a lot of stone extraction, but the evidence that it's actually very good is a little thin, and some of you will know there are at least 2 randomized trials that show that surgery is actually better for people with obstructive chronic pancreatitis than an endoscopic approach in terms of pain relief and indeed even cost, because most of the ERCP work requires multiple procedures. I'm not saying we shouldn't be doing it, I'm just saying that there are questions that need to be answered by really quality research. I particularly got involved with sphincter-avoided dysfunction, which, because towards the end of my ERCP career, I found that I was dealing with a lot of these patients with post-cholecystectomy pain. The practitioners are beginning to realize that that was kind of dangerous to do ERCP on these patients, and so they started sending them to experts, quotes, like myself, and I began to wonder whether, in fact, this was really good stuff, because indeed, this is a dangerous group of patients. These are healthy, middle-aged women, usually, who are not grateful when you gave them a really severe attack of pancreatitis or worse. The fact is that at that time, we're going back 10 or 15 years now, the outcomes of ERCP treatment, even claimed by experts, were never greater than maybe 2/3, and the post-ERCP pancreatitis rates were very high. As a result, we set up something called the episode study that some of you may be familiar with, where we took a bunch of patients with post-cholecystectomy with pretty much normal numbers, in other words, SOD type 3, although there were some 2s in there, and we randomized them they all underwent ERCP with manometry, dual manometry, and we randomized them to have a sphincterotomy or no sphincterotomy at all, so sham treatment. And at 1 year, we were slightly surprised to discover that there actually was no difference in the outcome in terms of pain relief. Those were not statistically significant differences, but they were impressive nonetheless. And we followed many of those patients for 5 years, and at 5 years, actually the sham-treated patients were doing better than the people who had sphincterotomy. So I've written about this extensively, the effect of all the placebo stuff that we do. I think these results are enough to make one think a little bit about what we're doing in an aggressive sort of way. We have some other studies going on in my group. We're looking at SOD2 and idiopathic recurrent pancreatitis. We've got randomized trials that you can see going on, getting started for looking at gallbladder dyskinesia, which is another thing as slippery as a wet bar of soap. We've got a randomized trial going on for minor papillary sphincterotomy and pancreas divisum, and looking at the prevention of post-ERCP pancreatitis, whether non-steroidals are as good as non-steroidals plus a stent. If you want to know anything more about any of this stuff, you're more than welcome to go onto my website, petercottontales.com, or send me an email. I will be reading it on Deweese Island, South Carolina, where I live. I may be able to answer you from the beach, and if you have any interest, you can also take a look at The Tunnel at the End of the Light, which I wrote about 10 years ago, which told some of these stories, and that's my first of my 5 children's books about Fred the Friendly Snake. If you have young children or grandchildren, or like me, great-grandchildren, you might be interested in going to petercottontales.com. I appreciate very much your being here tonight, and thank you very much for your attention. If there are questions or comments or corrections, I'll be happy to take them. Thank you.
Thank you very much, Peter. Do we have any questions? For Peter?
Why did he go on so long? Was that the usual question I get? Yeah.
People are often a little bit quiet at the start. But, advice for trainees going forward. Is there any sort of advice? There's plenty of trainees here tonight.
Yeah.
You know, which direction should they be heading? What do they need to do?
Follow your dream. When I started in gastroenterology, I was told there are too many people in it already in 1968. There's still a lot of opportunities out there. I think if there are things that you really enjoy doing, go and do the best you possibly can at them. How you get that training is tricky, but obviously it's essential to do that. So good luck.
You've obviously had a very extensive career. We don't have pictures there. I'll plug the Noosa update while I'm here. But do you have any regrets? You've moved all around. You've been a pioneer. Is there anything that you regret in your career?
Well, short game is terrible.
Okay.
No, what have I regret? Actually, I never thought about that. I've been very fortunate. I've had a challenging, a very, very exciting career. Met a wonderful woman halfway through. That's fantastic. What have I think I do regret. We talked about this briefly earlier about my sort of amateur, old-fashioned approach to training, to teaching. You know, I was of the old group that sat down and gave somebody 5 or 10 minutes on the scope, and if they weren't getting anywhere, grabbed the scope and finished the procedure, which was, and now I know very well, and I've studied with people who've shown me that training is actually something you can do rather better than that. So yeah, I think that's a legitimate regret. Yeah.
Okay.
Also, a lot of lousy research early on. I mean, I've done some decent research later, but when at Duke University, one of the faculty members gave a talk on bias in clinical research. And he showed 8 examples of biased papers, different types of bias, all written by me. So, I mean, one of my early papers was showing that endoscopy was better than the barium meal at detecting ulcers. The gold standard was the endoscopy report. So it's kind of not surprising that we came out on top. So some lousy research.
You're a pioneer. You had to be positive about endoscopy.
Yeah, no question.
Is there any other questions tonight? Okay, I'd very much like to thank Professor Peter Cotton for speaking tonight. It was fantastic to hear those stories. Thank you very much.
Okay.
Please register for NUSA. We've got a fantastic faculty. It'll be great to see everyone there. Thank you.